Hello, good morning, afternoon, and good evening to all speaker chairs and wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today is our honorable guest from United States of America, Professor Muhammad Abd-El-Barr. Professor Abd-El-Barr is an associate professor of neurosurgery and orthopedic in the Division of Spine at the Duke University School of Medicine, Durham, South Carolina. He's also an expert in the field of treating patients with spinal disorder with minimally invasive surgery or techniques. These include spinal stenosis, spondylolisthesis, scoliosis, herniated disc, and spine tumor. He also worked with Duke bioengineer and neurobiologists on important basic and translational questions surrounding spinal cord injury. He is also an important faculty who been invited to various conferences and workshops worldwide. He is also a noted author with many publications in various peer-reviewed journals. We are extremely honored to have him today at our webinar, and he'll be talking about pushing the limit of minimally invasive spine surgery from pre-operative optimization, intraoperative adjuncts to post-operative care. The speaker for the second session of today is our honored guest from China, Professor Xiaowen Wang. Professor Wang is an attending physician at the Department of Neurosurgery, Huashan Hospital, Fudan University, Shanghai, China. His clinical expertise is focusing on neuro-oncology. He did his PhD from the John Wayne Cancer Institute, USA, and he has won several awards and prizes for young neurosurgeons in his country. He also a noted journal with several publications in various peer-reviewed journals. We are extremely honored to have him today at our webinar, and today he'll be talking about update on the management of germ cell tumors. The chair for the first session of today's webinar is our honored guest from Pakistan, Professor Salman Sharif. Professor Sharif is the Chief of Neurosurgery at the Lakewood National Hospital and Medical College Institute of Postgraduate Studies and Medical Sciences, Karachi, Pakistan. He's also the coordinator of community activity for the World Federation of Neurological Surgeons. He's also the president of our World Spine Column Society, and he was the past president of the Pakistan Society of Neurosurgeons. He's an executive and education committee member of the ACNS and WFNS endoscopy committee member. He has been the torchbearer for the online education for young neurosurgeons in his country. He also was invited faculty to various conferences conducted all around the world. We are extremely grateful and honored to have him today to chair the session of Professor Muhammad Abd-El-Barr. The chair for the second session of today's webinar is our honored guest from India, Professor Suhas Udayakumaran. Professor Suhas is the professor in the Division of Pediatric Neurosurgery and Pediatric Craniofacial Surgery at the Amrita Institute of Medical Sciences, Amrita University, Cochin, India. He completed his specialization in neurosurgery from the King Edward Memorial Hospital, Mumbai, and therefore his sub-specialization in pediatric neurosurgery at the Dana Children's Hospital, Tel Aviv University, Israel. He has more than 50 international publications in peer-reviewed journals, chapters, and number of international conferences presentation. He involved in multiple research projects in neurosurgery in association with the Amrita Center for Neurosciences and Molecular Medicine. We are extremely thankful to Professor Suhas for accepting our invitation to chair the session of Dr. Xiaowen Wang. On behalf of the Education Committee of the ACNS and the President, Professor Yukato, I would like to welcome both the speaker, chairs, and the audiences to this online platform of the ACNS webinar. A warm welcome to our colleague in China, and we're extremely thankful to Professor Zubin for broadcasting this webinar on the WeChat channel. With that introduction, I would like to hand over this online podium to our first chair, Professor Salman Sharif. Professor, please.
Thank you, Boonseng. It's really my pleasure to be here. Today's webinar is on some innovative techniques which have been incoming. Minimally invasive surgery, we know, has been there for some time, but it's continuously advancing. It's pushing the boundaries, and people like Muhammad are those people who have been pushing these boundaries. you have this preoperative optimization of patients. So you've got proper selection, you've got tailored imaging, and through that, with the help of AI and advanced navigation system and instrumentation, we have changed the way the results are there for spine surgery. So that no more people can say, oh, with spine surgery, you have all these complications, etc. So all that has changed. On top of it, post-operative care innovations like enhanced recovery protocols, like quick recovery protocols have reduced the complications. And collectively, all these advancements have completely changed the way complex spinal surgery is dealt worldwide. And I think it's really my honor to be chairing this session when Mohammed is giving a talk. He's a dear friend for some time, and I've seen him work. And he's got brilliant over time as well. And he's working with the Duke Lab with various activities and have done a great job. And, I'm looking forward to hearing his talk.
Well, thank you so
Mohammed?
much,
Yep.
Dr. Salman, for the nice introduction. And thank you all to the participants and to the chairs for this wonderful invitation. It's truly great to see how the world has become so small, and we have people from all over the world, and I think this is breaking down the barriers to education and hopefully showing that innovation doesn't have to be one way, but it can be two ways, and we can all learn from each other. So today, the title of my talk will be Pushing the Limits of Minimally Invasive Spine Surgery. So in terms of the objectives of today, we're going to talk about the motivations behind minimally invasive spine surgery, and then we'll talk about important adjuncts to make this safer for our patients: perioperative care, radiation reduction. We'll touch a little bit on robotics, as well as some nerve segmentation work that we're working on. So when we look at the definition of minimally invasive spine surgery, we need to make sure that these surgeries are still effective. It shouldn't be minimally effective surgery. We still have to accomplish the goals of surgery. However, what we do with the overlying tissues on our way to doing the surgery, we have to respect. So a lot of people, talk about the incision and so on, but sometimes the incision is exactly the same. But what we do with the overlying tissues is the most important. If we look at Hippocrates, I think we can say he was a minimally invasive spine surgeon. When he said, when you're faced with two choices for a patient, you should always choose the one that's least troublesome. So we're going to start off with a case. This is an 87-year-old with mechanical back pain and bilateral leg pain. He has the past medical history of most of my patients here in the United States, and he has tried everything. He's had 3 epidural steroid injections. He's had chiropractic manipulation. He's had physical therapy. He's on pain medication, and he had the so-called laser spine surgery in 2011. If you look at his imaging, he has, the degenerative scoliosis that we would see in an 87-year-old. If you look more carefully, you see he's got a mobile spondylolisthesis at L4, L5. And then if you look at his MRI, he's got stenosis at L2, L3, stenosis at L3, L4, and stenosis at L4, L5 with the mobile spondylolisthesis at L4, 5 that we know about. So, should this patient even get surgery? I think that's a very fair question. As one of my partners used to say, the only elective spine surgery is the first one. And if the first one is not done well with the proper indications, then you start chasing your tail and things don't go so well. Sometimes they come to you with these pleading eyes. So one, just to kind of back up, we're actually using artificial intelligence now to figure out where best should patients go. So as you know, a person with back pain has so many different alternatives. And if you look at their clinical manifestations, sometimes it's a jungle. Depending on where they go first, that's going to, really determine what they're going to do in the future. And really, medical care should be a lot better than that. So what we're trying to do, and we have a publication coming out, is using artificial intelligence to figure out, with all these inputs, can we figure out exactly where these patients should go? And so that it doesn't become, a hodgepodge. It becomes much more systematic. We have to realize that surgery is traumatic for the patients and to the loved ones. And we really need to decrease our surgical footprint. I was invited a few years ago to talk about ERAS. I think ERAS is actually a misnomer. It shouldn't be enhanced recovery after surgery. It should be enhanced recovery with surgery. So from the very beginning, we should be looking at how to minimize the surgical footprint on these patients. So we look at four main phases of care. We have the preoperative care and optimization. We have intraoperative adjuncts. We have acute postoperative care and chronic postoperative care. So Dr. Shaffrey, my chief, has a nice talk on risk stratifications and when to say no. And we've worked a lot about this in terms of preoperative optimization. We've shown that, there are 8 modifiable things that really should be optimized before we take these patients to surgery. And in fact, when I see a patient in clinic and say that they may be a reasonable candidate for surgery, we have something on an electronic medical record now, which gives them these questions. And if any of these are yes, it makes a red flag and say, hey, make sure that you've optimized this patient before you take them to surgery. We also have something called the indications conference. This is something that I would encourage all departments to have. And we have a multidisciplinary meeting where not just the surgeons, but also the physiatrists and the physical therapists come together. And we say, hey, is this the right patient for the right surgery at the right time? And we also using predictive analytics to kind of figure out whether we can predict whether these patients will have complications with surgery. So after we've, done preoperative optimization, we've said that the risk of surgery is low and we want to do surgery, we have to realize that part of our footprint is not just surgery, but it's also anesthesia. So one footprint is definitely surgery, but also anesthesia is another important footprint that we have on these patients. So you should collaborate with your anesthesia colleagues. I'm blessed to have a great anesthesia team that I work closely with. And so if you look at how we treat these patients, surgery is just part of the day. So the patients come in, they have a preemptive analgesia, then they have some type of regional anesthesia block. And this helps with postoperative pain. And if they're a candidate for a spinal anesthesia, they'll have a spinal anesthesia. And then we have another pathway for the post-op pain management. I think regional anesthesia is something that I would say that neurosurgeons probably aren't as comfortable with. Our orthopedic colleagues use it a lot in their other surgeries. And this is something that we really need to pay attention to. So now we have a whole gamut of different blocks that we can use depending on the surgeries that we're going to do. So we have some blocks such as the QL block that will actually give you both anterior and posterior coverage. So for my anterior and lateral and posterior surgeries, I use this. Then I use the ESP for the T-lifts and so on. So right now, I think it's very important to do spinal pelvic parameters on every patient. However, we know that the spine is so much more. And so this is high definition MRI and segmentation of the bones, the nerves, and all the different pathways into the disc if we're doing an interbody fusion. So this is something that we've worked very hard on in the last few years. We can analyze every level and we can see, okay, Camden's triangle at each level, how big it is. And so we can choose, depending on the pathology, which level to go in on. So then if we're going to go posterior, what we've done is we've broken down the fusion surgery into different parts. And at each part, we've said, can we minimize the trauma to the patient to get their recovery better? So in terms of placing pedicle screws, we were all taught the kind of midline incision, go laterally, and then put screws from lateral to medial. So that, unfortunately takes the multifidus muscle off its insertion points and it doesn't grow back. So what we've been doing and lots of other people are doing are these paramedian incisions going in between the multifidus and the longissimus in this Wiltse plane. And then it's just a straight shot. So this is decreasing the muscle trauma to our patients. And we use radiographics for this. Minimally invasive spine surgery has a lot of advantages to patients, but one of the big disadvantages is in terms of fluoroscopy time. There can be up to 3 times as much fluoroscopy time. And this ionizing radiation is not benign. So as orthopedic surgeons or neurosurgeons that do spine, you have a 4 times lifetime risk of cancer and a 50% rate of cataracts. So this is not benign. So we've been working hard on this as well. We've developed this, what we call computer assisted instrument navigation. The fiducials actually go on the C-arm, any commercial C-arm. And then you have these infrared markers. And then you're able to track the instruments. And in fact, you can, because it's fluoroscopy centric and not instrument centric, you can actually navigate more than one instrument at a time. So you can navigate 2 screws at a time, which makes surgery much, much more efficient. So you can see here on the left side of the screen, I am navigating 2 Jamshides. It tells me where the tip of the Jamshidi is, and then also where I'm going to be. And each of these markers is 10 millimeters. So then, and this also shows me on the AP, I can put it on the AP, put it right at the edge of my pedicle, make sure that 20 millimeters, which is the length of the pedicle, gets to the medial side. And so then I can place perfect screws. So we published on this using not a match control trial, but we used each patient as their own control. So one side I would do normal fluoroscopy, and the other side I would do with the instrument tracking. We found that our x-rays would go down by 73%, our time was decreased by 63%, and our radiation was down by 73%. You can say, Dr. Abd-El-Barr, you're very fast, but maybe you're not so safe. So what we actually did is look at our accuracy, and compared to our robotically placed screws, we were the same at 97%. So not only is it faster, but also as safe as well, and safer than traditional fluoroscopy, actually. The next thing that we looked at is interbody fusion. So if we look at posterior, so this is what's called the TLIF. There really are 3 main ways. You know, there's the minimally invasive TLIF that a lot of the neurosurgeons are most experienced with, and that's doing a hemilaminectomy and going down here. But if you're doing that through a tube, you have a risk of a CSF leak, and if you're trying to put a big cage, you have a risk for a nerve root injury. You can go what's called a transfacet TLIF. This has been popularized by Zach Ray in WashU in St. Louis, or you can do the completely percutaneous way through cam bends, and this is I think very popular in Asia and so on. So we've been very interested in Camben's triangle. So we published this systematic review looking at the size of Camben's triangle. We found some very interesting things. We found that as you move more caudally in the spine, Camben's triangle area increases. Now L5S1 may be more difficult because of the iliac crest. And just like our endoscopy colleagues will tell you, if you do a foraminoplasty and you drill off the SAP, you can actually double the size of Camben's triangle. What we found also is that if you're operating, and as surgeons we deal with pathology, that actually pathology will decrease the size of Camben's triangle. And so you have to be careful about that. So this is how we kind of do it. We do the 2 Wiltse incisions for the screws, and then we have this incision here to getting into Camben's triangle. Now, before, when I used to try to get into Camben's triangle, I used to have 2 C-arms, one in the AP, one in the lateral, and this used to take me a lot of time to set up and so on. However, with this instrument tracking, what we found is that we can actually get into Camben's triangle faster than when we had 2 C-arms, and now there's no setup time. So this makes things much faster. Here is an example. This is a grade 2 spondylolisthesis, bone on bone, very difficult case. And you can see here how we're able to do this very easily. So the first thing here on the AP, we take an X-ray. We know how our instrument looks like. We're tracking that. Then we go into a lateral. We take another X-ray. And then this is the power of this software. It's able for me to see in real time where my instrument is without taking X-rays in both the lateral and AP dimension. So now I've taken 3 X-rays, and now I'm able to enter into the disc. And this is under neuromonitoring. And then I can adjust my C-arm and make sure I go across the disc here. And you can see I'm opening it up. Make some adjustments. There you go. And you can see now I've opened up this disc, and now I can do my discectomy and put my cage there. This case took skin to skin 47 minutes. So you can do very, very difficult cases very efficiently. How about the implant? You know, lots of people have talked about this bone in a bag. I felt that this was not a good construct, especially for younger patients that need solid fusions. So we helped develop a more robust implant. You have to protect the exiting nerve root. So we developed this instrument to help deliver the cage safely. So this is a expandable titanium cage that you can put through Camden's triangle. And we've published about this. So our first 16 patients, you can see here, we can get this surgery done in less than 3 hours. Our blood loss is less than 50 cc's, and patients are going home very quickly. And then we developed our first 50 patients, actually. And you can see here, we're keeping up with our radiographic outcomes. We're good. We have great clinical outcomes. And we're looking at fusion rates of upwards of 90%. We've also looked at adjacent segment disease, and we found that, you know, typical to any type of intrabody fusion, it's about 3% per year of needing another surgery at another level. In terms of robotics, we've been very active in this role as well. And I think I have a webinar after this one about robotics. You can use the robot to do both things in terms of placing pedicle screws. Lots of people have published about that, but we've also used it to place the intrabody. So what we do is use the robot to aim for Camden's triangle. And then we can do these cases. Here we go. We put in the screws, and now we're entering into Camden's triangle. And this is the first case that we did with the patient awake. And you can see there's no blood loss, and patients go home the next day. We've published about this in terms of a robotic trajectory into Camden's triangle. And you can see, you can do cases, 40% of these were done awake. You can see our blood loss is less than 50 cc's. How about the nerves? So our previous work kind of ignored the exiting nerve root, which is not good. So what we've done then is, you know, actually use the Brain Lab software. So this is bringing my expertise as a neurosurgeon. So we knew that we do these things for patients with brain tumors. So what we're doing is looking at the nerves as well. And we can then actually use this information to plan the side of our entry. And we can see traps before they come, so we can know when there's a conjoined nerve root and so on. What we found, not surprisingly, is that if you look at the nerve segmentation, yes, Camden's triangle increases, but putting the nerve into consideration will decrease the size of Camden's triangle. So you have to be even more careful. So certain projects that we're working out now is actually, can we automate this process? And then what I'd like to do in the future is, instead of looking at a screen while I'm entering into Camden's triangle, actually look at the patient using augmented reality. And we're working on that as we speak. So this is a case, a grade 2 spondy case, a 70-year-old lady. And you can see that, you know, she had this spondylolisthesis. This is the way we do it. We get an erector spinae block. We do the spinal anesthesia. We bring her in. We put in these screws in using the instrument tracking, using the Wiltse approach. This takes us about 40 minutes, which is much faster than before. This is, you know, percutaneous. And then, you know, it's my standard operating procedure if I put in screws to get a CT scan. So we get a CT scan and we put a fiducial on the PSIS. And then we actually merge the CT to MRI. And then we can actually go percutaneously into the disc, avoiding the nerves. And so you can see here in this video, we're entering into the disc percutaneously, avoiding the exiting nerve root, avoiding the traversing nerve root. And we can do this case completely percutaneously. We'll do a 2-level TLIF with less than 50 cc blood loss. And we have these patients going home the same day. If you had told me in my fellowship that you could do a 2-level TLIF and have a patient go home the same day with 50 cc blood loss, I would have thought you're crazy, but this is now a reality. And, you know, we also always check our spinal pelvic parameters. We've done very well on that in terms of as well. So now, as we've become more and more efficient, we've become more and more reluctant, maybe perhaps, to do these surgeries, because as we studied more, we found that some people, their Campbell's triangle is too small. This person here, their Campbell's triangle is only 6 millimeters. And so it would be dangerous to try to do this percutaneously. So, I encourage our trainees, just because you learn one technique doesn't mean that that technique is for every patient. You should learn all the techniques and use them for the appropriate patient. So we've looked at other pathways to the disc. The other pathway is the transfacet pathway. And here is a comparison of the transfacet to Campbell's triangle. This paper was just published in Operative Neurosurgery. And we can see that the transfacet pathway will actually be larger in most cases. So here's a case, a 30-year-old gentleman with a grade 2 spondy. You can see he's not a good candidate for an ALIF, not a very good candidate for a lateral. So we're going to do this posteriorly. So again, we use this segmentation. We plan a transfacet trajectory. We put in the screws again. We merge the CT to MRI. And then under the microscope, we have this heads-up display or augmented reality where as I'm drilling, I can see the nerve through the bone as I'm working. And again, you can see you can get excellent post-operative results. This person also went home the next day. And now with this transfacet pathway, since it's bigger, we can actually put bigger cages that expand both in the up and down and also medial laterally. So you can see you can almost have a ALIF footprint all through posteriorly. Now, if you're paying attention, you'll say, well, Dr. Abd-El-Barr, your Campbell's triangle way and your transfacet way doesn't really do a decompression. And that's true. And we know that, doing a decompression is important. And so that's where endoscopy can come in. So perhaps we can do these things percutaneously and then use the endoscope to go in and do a bilateral decompression if needed. Now, you've seen that we've done some awake surgeries, and we've been interested in that as well. So why would we want to do awake surgery? We know that general anesthesia is not benign. And so we've looked at this as well for awake fusions. We've published this matched cohort study, matching these patients in terms of their age and BMI and the surgery that they did. And we found a few things. We found that the length of stay for the spinal anesthesia was much lower. Also, importantly, is that 50% of the spinal anesthesia patients take no opioids after surgery. So this is an apples to apples comparison. It's not a randomized control study, but it is a matched cohort study. However, we also found that the spinal anesthesia opens to the door to a bunch of oranges that simply were not good surgical candidates. And so we've published on this as well. Here's an example. This is not my work. This is somebody in another state, was a 91-year-old who had a compression fracture at L5. They had a kyphoplasty under general anesthesia. This person had pulmonary hypertension, coronary artery disease, was 91. It took them 5 days to extubate the patient. Unfortunately, when they extubated the patient, they found that they had now, the back pain was better, but they had now bilateral radiculopathies due to this compression of the cement. And so the surgeon there, told the patient, I'm really sorry, but I can't do another surgery on you. It took me 5 days to extubate you. I think that you may not be extubatable after a laminectomy. So she came to our place. We did this under a spinal anesthesia, awake bilateral decompression, and we had her home the next day. And now she's actually 2 years out and is very happy. So this, again, opens the door to poor surgical candidates for surgery. So going back to our patient that we started with, this is an 87-year-old with 3 levels of disease. Very difficult, right? The spinal anesthesia only lasts for 3 hours. How am I going to do 3 levels of surgery on this patient safely? And so again, to the trainees, be involved, be engaged. So this actually was a help of one of my fellows who's now attending at Columbia University, Dr. Andrew Chang. So what we did is we did the following. We actually brought in 2 microscopes. So this may not be applicable to places that have limited resources. I think this took a lot of resources. So we brought in 2 microscopes and we did the same thing. We put in the screws, and then I worked on the interbody fusion while Dr. Chan on the other side was doing the decompression. Now, this was kind of a dance. And you can see here, I think this is a really cool video. So on the left here is me doing the interbody fusion, while at the same time, Dr. Chan is doing the bilateral decompressions. This is simultaneous. So then again, we're able to reduce the spondylolisthesis. We put this big cage here to reduce the spondylolisthesis. This is a percutaneous surgery. So less than 3 hours, 50 cc blood loss. And on this 87-year-old, we were able to get him home the next day. The best part about it, and we've published about this in parallel technique, is that 3 months later, he sent me this video of him riding his motorcycle. So we're able to get these people that were, bedridden back to the activities that they enjoy. So we've talked about awake surgery to avoid the complications of general anesthesia. As a neurosurgeon, I'm very used to doing awake craniotomies to look at eloquent cortex and measure the function of eloquent cortex. So as a spine surgeon, there's nothing more eloquent to me than the nerves. So we've done this in limited cases, and that's using only local anesthesia. So we don't have a spinal. And so then we can actually monitor nerve function as we operate. So this is a 73-year-old who previously had a 2-level laminectomy and had bilateral S1 radiculopathies. And he had went to several other people, and they said, unfortunately, the only thing left for you is a fusion. But he said, I don't have back pain. Why are you going to do the fusion? So this person was very committed to the cause. And so what we did for him is a bilateral endoscopic decompression transforaminally using only local anesthesia. And so again, we use the instrument tracking to help us enter into Camden's triangle. Just skip over that for time. And then as I'm doing my foraminoplasty, this is me just taking some tissue off. Now I'm opening up the foramen. I'm drilling the SAP. You can see there's the ligament. As I start taking that ligament off, he tells me on the table, because he doesn't have a spinal, my leg pain is better. And now there's no spinal to wear off, so he can go home right away. So I think that kind of talks about all these intraoperative adjuncts that we're using to help our patients. In terms of acute postoperative care, I have the physical therapist come to the recovery room right away. So we get the patients up right after surgery. And so there really is no reason for them, if their pain is well controlled, they're able to walk, they're able to void, they can go home right away. And this, we know, improves our quality, right? So if we have early ambulation, we have improved quality outcomes. In terms of chronic postoperative care, a lot of patients now are using electronic things. So why don't we have a mobile app that lets us kind of keep track of our patients? And so we have this app here that patients can tell us how they're doing. And we can also have automated signals to the patient. Hey, you're post-op day 5. You should be having some pain. This will get better, and so on. And we actually showed that having this mobile app will decrease our ER visits by about 35%. So I don't want to take too much more of your time. I'll close it up so that we can have questions. I think the future of spine surgery is individualized care, and that's something that I hope I've demonstrated. We want to have the right surgery with the right patient. We want to use these regional anesthesia and awake spine surgery protocols. This nerve segmentation is really helpful to make our surgery safer. And we want to choose the best approach for each patient, not based on our own biases, but on what the patient's pathology really shows. We want to use these intraoperative adjuncts, endoscopic, advanced robotics, augmented reality, and these different types of fusion devices that allow us to make a good construct, but not have a lot of footprint on the patients. And in terms of postoperative care, we want to look at our patient-reported outcomes. We want to look at advanced imaging. And I think these mobile apps are going to be the future to keep track of our patients. And as I say to my residents, I really think the future is now. So just to conclude, I think minimally invasive spine surgery is exciting for me as a physician, and it's exciting for our patients. And again, patient-specific and pathology-specific planning is extremely important, and really a close collaboration between anesthesia and nursing, physical therapy is really, really important. And with that, I'll conclude. Thank you so much.
Thank you, Mohammed. I think wonderful talk as expected. You covered everything. I just have a question for you. Of all these measures that you've taken to improve where you are today, which one thing that you'd say made the most difference, starting from pre-op, operative, your innovations, post-op, and all the care, post-op care scenarios, etc. So, which one thing you'd say that made a huge difference of all these things?
Yeah, that's a great question. And we're looking at it. So we're looking back retrospectively because it's been definitely a learning curve. So I've brought different parts to this procedure and so on as time has gone. I don't know that I have the answer data-wise right now, but I think that the biggest difference is the I would say is probably how fast we do the surgery. I think that what we'll see, right, and there is data for this, right? The less time that you have a patient in the operating room, the much better they do, right? So if I can do a TLIF, so yesterday I did a TLIF on an 80-year-old. She couldn't tolerate being awake, so we had to put her to sleep, but we still finished the case in an hour and 10 minutes, right?
Wow.
That 80-year-old, right, went home the next day, right?
Brilliant.
Because
Yeah.
right? And so I think actually you can use all these different things, but time is quintessential for these patients, right? The less time that you can have them on the operating room table, the better it is for them. And I think that's borne by the deformity data, right? And that's why, for deformity cases, we'll bring in 2 attendings so we can move faster. We know that just being under anesthesia, even spinal anesthesia, makes a difference for these patients.
Brilliant. There's a question from my friend Harshad Parak, and he's asking what is maximum advantage of endoscopic surgery over microsurgery, which can be done in regional anesthesia?
Yeah, great question. I think that where endoscopic really shines is in the transforaminal space. So people that have foraminal discs or far lateral discs, doing that surgery even with a tube can be very painful. Doing it endoscopically is almost become too easy. Like sometimes I feel like I'm cheating the system because I can do this transforaminal with this image guidance. I can get into Camden's triangle in literally 2 minutes. I can do the surgery in about 10 minutes. You can't do that surgery with 10 minutes with a tube for a foraminal disc or a far lateral disc. In terms of our typical discs and over-the-top decompressions, I don't know that the bang for your buck is as much. Another place where endoscopy really shines is cervical endoscopy. So doing cervical foraminotomies now has, for me, become an outpatient procedure. And patients actually don't even want to stay a minute in the hospital. They go home from PACU. I think the holy grail, if I can use that word, is going to be thoracic discs. And I can't say that I'm the best at thoracic discs now. I have some colleagues that do thoracic discs, and cases that would traditionally need a fusion and so on. Now they're having these patients, go home the next day. So I think that there are areas where endoscopy is going to really shine through, but I think admittedly there are going to be areas where the difference between endoscopy and microsurgery is not going to be as big.
Okay, brilliant. Any more questions, comments?
Yeah. Thanks, Professor. Can I ask some question, Professor?
Sure.
Thanks, Professor. Very brilliant presentation. I would like to ask 3 short questions. One is regarding the fixation. As neurosurgeon, fix the skull for image fusion is very easy, but spine because of the segmental movement. Sometimes we may not getting the accurate one. And in my practice, we always use AI to be sure. We think that would be some advancement in the future to avoid these problems, and whether now you think that in the future I can have some AI in it where it's easier to do a squaring of the vertebral body, for example, less fluoroscopic time. What do you think? A second question regarding keyhole surgery and single trajectory surgery, because I find the keyhole surgery just a misnomer, just look nice outside, but it's not so much inside. So what's your opinion regarding single trajectory and keyhole surgery? My last question, Professor, do you find that by giving LA is better form of neuro monitoring than having a neuro monitoring itself? Thank you, Professor.
Great question. So the first question about the fixation and using different methods to understand that, I definitely think that, you know, we're behind in that. Now, some of the things that gets a little bit complicated, you know, when you're doing brain surgery, you can use the skull as a way, and the skull has a lot of regional anatomy that you can have deep learning to understand. The spine, especially if it's percutaneous, kind of all looks the same. You know, so figuring that out will be difficult. We're actually working on that as we speak, and so I don't think that we're there yet, but I think it will get there. In terms of the keyhole surgery, you know, it looks good from outside, but inside you may not have as well view. I think that's a part of the learning curve, right? Is that we have to spend some time to really understand. You know, when we went from open to tubular, there was some learning curve, and now when we go from tubular to endoscopic, there's also some learning curve, and you spend a lot of time trying to figure out. You know, maybe you spend the first third of the operation trying to figure out where you are. These adjuncts kind of help do that, but that definitely is something part of the learning curve. In terms of the local anesthesia, I think that there are definitely some advantages. So there's a mantra that says, I'm gonna do it in two parts. One mantra that says that you can't monitor under spinal, actually proved that that's wrong. And we showed that you can actually monitor. So I don't want to sacrifice safety. So I actually monitor all my cases. So even the spinal we monitor. And then under local, the patients work as their own monitor. And we have some interesting results that says that you can use both of them at the same time, so even maximize the safety.
Thank you very much.
Any other question? Just a quick question again. Well, you know, my concern about transfemoral disc surgery is the recurrence. And, you know, when I talk to my Korean friends, they say that they keep their patients in bed for a week. And the reason they give is that if you mobilize them early, they're going to have a recurrence. What's your experience? Do you do that as well?
No, I wouldn't have a job if I get my patients in bed for a week. No, I'll have to look back at my data. I think that the recurrence rate is not so high. That may be the fact that I don't do as much bony work if I can avoid it. If I can enter into Camden's triangle, find the disc, I will not, if I can, destabilize the structures as much as I can. And partially because of my experience with the local anesthesia, I don't think, I think as neurosurgeons, we have this mantra that we need to see the nerve and we need to see it so happy and so on. That may not exactly be true. Because of the work we've done with the local anesthesia, I found that you don't have to decompress the nerve that much. Getting the pressure off the nerve may be, quote unquote, sufficient. So I probably don't do as much bony work, and I probably don't do as much nerve work. And so that, I think, minimizes the instability that can happen. And so I have not put my patients under those types of restrictions.
Brilliant. Thank you. I think it was wonderful having you here. It's been excellent. I'd give the mic to our friends in ACNS to carry on.
Thank you so much.
Thank you, Professor Salman. Sorry for chairing this session, and thank you for a great lecture, Professor Muhammad. And now we usually close the first session. We move to the second session for today's webinar. Meanwhile, for your information, We have more than 360 audiences from different platforms of our webinar, from the Zoom, YouTube, and also from the WeChat channel. Let me hand over this podium to Professor Suhas to chair the second session.
Thank you, Dr. Bunsing. Thank you, ACNS, for allowing me to be the chair of the session. A very important session in pediatrics, and so welcome, Professor Wang. Let me start off with some basic points of CNS germ cell tumors. They are very rare tumors, and it's very rare in our part of the world and the Western world, and of course. So that hence there's a lot to learn from you and any of our colleagues in the East. But at the same time, very interestingly, these tumors are highly amenable to treatment in terms of chemo and radio. But ironically, the long-term quality and the latest markers in research, the bench research, becomes very important. So hence, the update is a very, very important topic as of now. Welcome, Dr. Wang. Go ahead with your talk. So your floor is yours, please.
Thank you for the introduction of Professor Shuha, and thank you for the ACNS seminar. It's a very great platform for young neurosurgeons to learn, and for me as well. So it's my honor to present some updates of the germ cell tumors, especially intracranial parts. Intracranial germ cell tumors actually is a part of the pediatric brain tumors. So we'll begin with the pediatric brain tumors. It's a most common solid childhood tumors, and only second to leukemia is a course of pediatric malignancies. And it's different from adults, including size effects, because the pediatric brain tumor usually affects the midline parts. And also, the treatment is more comprehensive, and the prognosis are different. And for kids, usually present with non-specific symptoms, so usually ignored, and the diagnosis is usually delayed. So, in the pediatric brain tumors, and one of the tumor is intracranial germ cell tumors. And the topic we'll share today is a subset of extracortical GCTs that arise within the central nervous systems. So without evidence of the primary tumors, or either in the test or the ovarians. Like other extracortical GCTs, intracranial GCT typically arise in the midline locations, so such as the pineals and the suprasellar regions, and either single or bifocals. So they affect primary adolescents and young adults, which a peak incident in the second decades of life. So here is some importance for the intracranial GCTs. The first is epidemiology is quite special. I will summarize it like Asian little boy, because the incident rate is in Asia is much more than Western, and also it affects the adolescents, and there's a boy dominance, especially for pineal regions parts. So our center is a National Centers for the Neurological Disease, so it's our responsibilities to have more research on this disease. And also the classification is complicated. I still remember when I first know about GCTs, I was confused because there's a lot of subtypes of this disease. So how to understand this disease, maybe embryonic development, is a good angle for us to know about this disease. And the third is the treatment strategies is quite diversities. And so we have to update, and also we have to have a standard protocol, especially in our center, how to treat this disease. And also the prognosis. Right now, this disease, the prognosis is much better than before because of the MDT and also the multi-tech supports. So here's the framework of my talk today. Tonight is the first one is epidemiologies and clinical features. So the incidence rate of the intracranial GCT is 3 times in Asia than the Western, but in the portion of the pediatric CNS tumors is 5 to 10 times in Asia than to Westerns. And the peak of this disease is 10 to 20 years, and the median age is around 10 to 14. And there's a male dominance in the pineal GCTs. And the location, as we know, is pineals and cellular and basal ganglions and the bifocal. So when there's different locations, there has different features, clinical features. So usually have obstructive hydrocephalus and pre-node syndromes when the tumor located in the pineal regions. And also there will be a vision and visual field deteriorations and polyurias and polydipsias, previous puberties and developmental retardations in the cellular regions. And also have a limbs weakness in the basal ganglia regions. So for the classification, we know that generally we have a germinoma and non-germinomas germ cell tumors. So in the NGCCT subset, there will be 7, including 3 teratoma, mature or immature, or teratomas with malignancy transformation. And the other 3 is embryo carcinoma, Yolk tumors, and cholangiocarcinoma. And then the final one is a mixed GCTs. So for these different tumor types, it has different tumor biomarkers. And their previous one is AFP and beta SCG. So we know that in the pure germinomas, there's negative in both tumor biomarkers. But once you have when you have a sensitotropic plastics in the germinoma, you can have a slightly elevated in beta SCG. But the level it will not high. So in this case, is your tumors you are gonna to have a very high AFP, and for the cholangiocarcinoma you have a high, very high beta SCG, and for the mixed GCT or immature, you may have an elevated of the tumor biomarkers, but sometimes not so high. And for the mature teratoma, there will be negative in both biomarkers. And only for these 2 markers, but also have PLAP. So right now, PLAP we usually use in monitoring the treatments during monitoring PLAP during the treatment. And the c-kits usually used in the IHC. So there's an correlations between the radiologic findings and pathologies in IHC and tumor markers. So here we know that the germinoma is, you can see a large undifferentiated cells because it's more undifferentiated tumors. And for mature teratoma, you can see the full differentiated entirely. And for the immature, you can have some incomplete and differentiated elements. And for these 3 types, and especially for embryo carcinoma, you can see some large epithelium cells forming absorbed papillary and glandular structures. And for cholangiocarcinoma, you can have a cytofibroblastic elements or cytotrophoblastic giant cells because they contain a lot of beta SCG secretins. And the Yolk tumors, there will be primarily looking epithelium cells with a putative differentiate towards Yolk epithelium cells. So, and when we look into the IGCTs, there will be 2 questions you will always ask. The first question is why the germ cell tumors grow in brain? Why not in Golda areas, but why in the brain? So there will be a hypothesis, and recent research will reveal that it may be a theory of pyramidal germ cell theories. So we have PGCS migrations. And the other question is why there are so many subtypes in IGCTs. There will be another hypothesis like a stem cell theories, stem cells differentiation. So first we'll look into the PGC. So after 4 months and 6 months of the embryo development, then the yolk sac, so the PGCs will traveling around and then goes to the genital ridge, which if everything goes well, if the PGC goes its destination, then it will exist and go to this way. So the PGC then will be grow and then differentiated and then to the testis or the ovarian. So this is the normal track. But once the PGC fail to exist the nerve branches at the gontocyte, and he may continue to go along the sympathetic trunk on the midline of the bodies, and they may end up in other distant sites, including the retroperitoneums, abdomens, anteriors, medullarians, neck, and also the midline of the brain. So that's why they're abnormal and the migrations from their genital ridge then to their midlines. And then early GCT, once it goes to like this tree, goes to the midline of the brain, the cells usually goes to apoptosis, but some will be reprogrammed to primed embryonic stem cells, the ESC, and then this is can grow into the benign teratomas, and then the transform late PGCs. It makes you reprogramming to embryonic carcinoma cells, which then goes to their malignancy counterparts of the naive ESC, and then it can go to the other non-germinomas with variety subtypes. So that's the reason why it has a lot of subtypes. So we can summarize with this. So once there's a PGC here, then it goes because the migration to the midline of the brain, and then goes because the reprogramation and transformation, then it goes to different level of differentiation. So the normal level goes to the normal testis or ovarian, and once there's a differentiates to embryonic, and then it can go to embryonic carcinoma. So once it goes to the extra embryonic, then it can go to yolk sac tumor or choriocarcinoma. And if there's no, it was undifferentiated, then it will stay in the germinal states, then it goes to germinoma in our brains. So that's the embryonic development angles to help us to understand the GCTs and different subtypes in our brain. So once after we know about the GCTs, then comes to a clinical question is how we make a diagnosis. So there's a summary of the diagnosis from different treatment groups, including SIOP, COG, Japan, and Korea, and Taiwan, and also we have in our Huashan. So for the germinomas, here we know that is the pathology confirmations of the component of the germinoma and AFP and SCG, which is lower. So we can see that majority of the groups. So for the AFP is less than 10, and for the beta SCG is less than 100, and some are like 50. But the most important thing is that the pathology plus the tumor biomarkers and so that's for the germinoma. But for the NGGCTs, we'll see is all. So either you have a pathology confirmation of the component of cholangiocarcinoma, your subtumor embryonic carcinoma, or you have an elevated AFP or elevated beta SCG. Either one, you can make a diagnosis of NGCCTs. So then it comes to the treatment protocols. So here's the recent publications that shows the Japan's guidelines for the intracranial GCT treatments. So it's a quite a good guidelines for me because it's more clinical question based. So when we have a clinical manifestation of CNS germ cell tumors, then it comes to the radiological examinations first. Then we have to management of the tumor biomarkers to make a diagnosis. So whether it's you see whether it's a germ cell germinoma or NGCTs, but before you make a decision, usually you have an urgent case is whether you have a hydroceptors or not. So once you have a hydroceptors, then it goes to here. So you goes hydroceptors you here. So your tumor marker is low, means that you have you might be germinomas with hydroceptors. Then EVD or ETV will be performed, and then goes to a biopsy. Yeah. So once you don't have a hydroceptors, and then if you have a tumor marker is positive, then you goes to NGCCTs. So NGCCTs, then if in NGCC you have a mature teratoma, you have to surgery because it will be the chemo and radio will not effective in the mature teratomas. So excluding the mature teratomas, then it goes to the chemo and radio. Then you have to assessment, see whether the tumor is gone or not. So if there's a rescue tumor, then goes to the surgery, we call it second root surgery, and then goes here. So if you have germinoma, then it goes to chemo and radio, and then you assessment for whether the tumor is rescue or not, and then goes to follow up. And so so in these guidelines, it highlights that first you have to measurement the tumor biomarkers. And then for the hydroceptors, it's more prefers to do the ETV, and also for the germinoma case, you don't need to operate. You only need biopsy for this case. So for the Europe and the North America studies, so for the protocols is first you have to define is a pineal, suprasellar, or ganglious regions, or bifocal. So then you have to have a CSF and the serums for the tumor biomarkers. Then you have to assess whether it's localized or metastatic types by the CSF cytologies and spinal MRI. So after this, then you make a decision whether it's a germinoma or it's a non-germinoma. And so if it's a germinoma, then it depends whether it's localized or a metastasis. For the metastasis, then here is you have to do the craniospinal irradiations with the boost, and but for not localized, then you don't need to do the CSI. But for the GCCTs, whether you are metastasis or you are not metastasis, then you have the chemo plus the CSI. So there's a little bit different, different between the Europe and the North America. So here is in the Europe, then for the metastasis, metastasis pure germinomas, so they do the radio alone. So, but for the non-metastasis pure germinomas, they do chemo plus radio. As we know that the radiotherapy is a standard protocols for GCT in the old days. So, but why here they use the chemo plus radio is to trying to use the chemo to reduce the dosage of the radio, which can reduce the toxicities and the cognitive effects of the radiotherapy for kids. Yeah, so and this is the guidelines in China, which was written by Professor Zhang Long in our center. So here for the germinoma treatments in our center, here is we have two. So there will be two options for germinomas. We usually did in our center is we do the radiotherapy alone. So for the non-dissemination, and so we will use reduced dosage of a CSI. And for the dissemination, so we will use the CSI 24 grays, and in wall field radiations boost 16 grays. And in other centers, they will do chemo and radio as well. And for NGCCTs, the standard treatment is chemo and the CSI and IFRT boost. So those are the protocols and the guidelines, including Europe and Japan and China. So after the treatments, we are usually we will think that how's going with what's the outcomes or the prognosis of this disease. So according to the recent publications, that we can see that the results and the outcomes of the germinoma is quite good. The 5 years overall survival is 98%. So in different group, because of the here is because of their for the ACNS this study, because they have more strong chemo and also they have a CSI, so the overall survival is better than the other groups. So and for some publications recently is that the overall survival, so this is the germ cell germinomas, is like around 99%. And here is the NGCCTs, even for their choroidal carcinoma or embryo carcinoma and Yossac tumor, those are we'll call the poor prognosis subgroups according to the Masutani classifications in the previous decades. So even for this, the 5 years survival rate is still around 68 to 87. So the general overall survival for this disease is much better than before. And because that is because a lot of the reason is, the first one is we have multiple texts and them before. We have neural navigation, intraoperative neural monitoring, and sometimes we have a intraoperative MRI. We can have endoscopic, exoscopic with surgery, and even for some we can have robotic biopsies. Those are techniques improvements we can help. And the other case is that we have MDTs for those GCT. We have a GCT clinic, including their neurosurgery and the radiologist and the endocrinologist and neuro-oncologist. And we have our MDT round for those kids, and we have annual MDT meetings, especially for GCT patients. So in our centers, we have our protocol is that we summarize it ABC for intracranial germ cell tumors. So once the patient was IGCT suspected, so we have to have an assessment and have a bi-step treatment and a close follow-up. So in the assessment, so in the pre-treatment assessment, we have to have to assess whether it has hydrocephalus or teratoma by the CT or MRI. And then for tumor markers, CSF or serums, and to differentiate whether it's a germinoma or GTCT. Then also dissemination status has to be checked by the CSF cytology or whole spine MR. After the treatment assessment, then we can classify it into different subtypes. So it's germinomas with hydrocephalus, germinoma without hydrocephalus, NGCC with hydrocephalus, NGCC without hydrocephalus, and also teratoma. So for germinoma with the hydrocephalus, we'll do ETV and biopsy together in two burr hole and to release the hydrocephalus as well to gather the sample in one operations. And so for the germinoma without hydrocephalus, then we'll do biopsy. So either in the basal, so either in the basal ganglia regions or in the cellar regions. So for the cellar regions, usually do sometimes we'll do endoscopic, sometimes we'll do eyeball or ASO, and so when it goes to then once the pathology confirmed it's a germinoma, then goes to radiotherapy. So if it's NGCT with the hydrocephalus, we'll do ETV for those cases. But if there's no hydrocephalus, then it goes directly. So both of NGCT will all goes to chemo. So after the chemotherapy, we have a inter-treatment assessment. I mean, including the clinical symptoms and also tumor markers and CSF or serums to check the AFP beta SCG whether it's increased or decreased, and also the MRI to check the tumor size. So then they will go to into different status, including CR. So its tumor residue is negative and the tumor biomarker is negative, and then goes to or a PR, means the tumor size is still there and shrink but not disappeared, and the tumor biomarker, however, the tumor biomarker is already negative, and or the SD, for some cases they have a chemo resistance. The tumor size is stable, and the tumor markers is stable. So and the other one is the PD. So usually happens in GTS, growing teratoma syndromes cases. So the tumor size enlarged and also have a clinical deteriorations and the clinical worst. So once there is a CR, usually for the germinomas, it goes to this way. Is CR, then we will keep on going for the radiations, then we goes to the follow-up. But if the chemo, so the NGCC after the chemo is PR, SD, or PD, then we goes to the surgery. So after the surgery, then we goes to continue the chemotherapy to reach the total for 6 courses. Then goes to the radio, then goes to the close follow-up. So for the follow-up is including tumor recurrence, brain contrast MR, and tumor markers to see whether the tumor is recurrent or not. And then is tumor metastasis, and usually in the spine MR scans, and also the endocrine hormone replacements, and also the quality of life, including cognitive level, limbs activity, and visual activities. So that's the protocol we perform here. So and then I will share some cases we according to our protocol. The first case is a germinoma with hydrocephalus. So It is a 30-year-old female and admit in our ER because of the hydrocephalus presented with the primary paranoid syndromes. So the serum and CSF markers were negative. So this is CT scan and MR scan and reveal pioneer joint lesions with obstructive hydrocephalus. So the spine MR were fine. And sort of pre-diagnosis pioneer region lesions, GCTs, and obstructive hydrocephalus. So we do an ETV plus biopsy by 2 burr holes. So the anterior one is for the biopsy and the posterior one is for the ETV. So we first do an ETV and then we do the biopsy. So the frozen pathology review a germinoma and the biomarkers were negative, and also CSF cytology later on shows negative. And the final pathology review a germinoma. So, and this is a post-op CT and MR. So here it's a germinoma with hydrocephalus. So we resolved their obstructive hydrocephalus and also got the pathologies. Then it goes to it goes to radiotherapy. So this is the pre-radiotherapy. This is the intra-radiotherapy. So only for around like 10 times. So the lesion was gone. This comparison before and post-op radiotherapy. So for the germinoma with hydrocephalus, so ETV could be performed to resolve the obstructive hydrocephalus, and ETV and biopsies can be performed if possible, and so we can resolve the hydrocephalus and got the pathology at the same time. And there's no necessary to operate on the pure germinoma cases, and also radiotherapy is very effective on those cases. And the second one is NGCCTs with their hydrocephalus. So we treat it with ETV chemo operation, then the chemo radio, and finally we achieve a CR. It's also a 16-year-old boy, and confined the pineal regions for 2 weeks, and because of the obstructive hydrocephalus, so he has to have a emergency EVD in local hospital, then transferred to our center. So the lab test shows the extremely high AFP and slightly elevated BLS-CG. So this is the CT scan after the EVD in local hospital, and then trans our hospital. And MR scan review our pineal regions joint lesions. And because it's the EVD, so in this case, we plan to do an ETV and drill out the EVD, and at the same time we also got a biopsy for this case. So this is post-op ETV, and it's interesting that here their pathology is the germinoma. So we remember that for those GCT cases, the diagnosis should be careful, including pathology and also tumor biomarkers. So even the pathology here is germinoma. However, because the elevation of the tumor biomarker extremely FP, so we also diagnose it as NGCCT. So because the NGCCT and with the hydrocephalus, and the hydrocephalus has been resolved, so it goes to chemo in our protocol. So this is the first course. So we see it's stable, and for after the first chemo, we see here that the tumor biomarkers not go down dramatically, and then goes to the second course. It then goes up. So this is the second after the second course. So give us a vision that it has the PD. So this is the comparison before chemo for one course, chemo for second course, then this is the pre-op, so the tumor enlarged. And so the diagnosis pineal region lesions, so we used the lab open approach. So first we collected tutorials, and then we found the lesion was tenacious, blood supply was still abundant, even after 2 courses of a chemotherapy. And the boundary was clear. We dissect the lesion piecemeally and finally exposed the subventricle and aqueducts. And and the lesion was strongly adhered to the midbrains. And finally, we achieved total resections, and the vein of Galen was protected well. And the pathology will reveal a York tumors. So the intraoperative SDPMEP, and this post of CT and MR scan. And then this is the post of our MR scan. So after the tumor resections, the tumor biomarkers drop dramatically, and then after the chemotherapy, then the tumor biomarker goes to CR. Finally. So this patient goes to 6 courses of chemo, and then radio, and finally the tumor no residues, and the biomarker was negative, and the boy is getting quite well. So in these cases, those cases are NGCC with hydroceptors. So be treated with the EVD or ETV, and so the NGCC and the chemo need close follow-up and assessment. Once the tumor did not shrink, the attention should be paid in case of the tumor enlarged quickly. So here in this case is because maybe because of the chemo resistance and for these York tumors. So it's not a growing teratoma syndrome because of the final histology was not the germinoma, no teratomas. So in this case, surgery should be performed quickly, immediately. And joint pineal tumors could be caused midbrain compressions, accompanied with coma, CSWS, and post-op care should be complicated and needs a lot of efforts. For this case, yeah, we pay a lot of efforts, or make a lot of efforts on his recovery. And therefore, the third case is the NGCCTs, and without hydroceptors. So it's a 6-year-old boy and precious purity for 3 months, and has their beta-SCG elevated. So CT and MR scan reveal a lab basal ganglia lesions with enhanced. So due to their tumor biomarker and the location, and then we do an assessment. So NGCC was diagnosed. Then we go, because there's no hydroceptors, so we goes to the chemo directly. So we see after 1 course, then it goes to CR. And also we check the MR, and also have imaging CR as well. So for this course case is a chemotherapy for 6 courses, and also goes to radiotherapy, and the tumor residue negative, and tumor biomarkers negative, and then this boy got CR. So for those cases, NGC with hydroceptor could be chemo if it could be rule out the teratomas. NGCC and Bank-Skin usually with their beta-SCG elevated, and which is quite effective with chemo. Even though chemo achieves CR for these patients, radiotherapy should be done to enhance the outcomes. So the final case is the NGCC with growing teratoma syndromes. There's a 9-year-old boy in 5 pineal regions and primary treatments for 6 months in other hospitals, and follow up with the lesion enlargements for 2 weeks. So also presented with the pre-noise syndromes. And this boy has primary treatment by GKS and VP shunt in local hospital 6 months ago. So the serum and CSF reviewer AFP was elevated. So this is the CT scan before their primary treatment in local hospital, review of pineal region lesions. And so in local hospital, they make a primary treatment in local hospital that diagnoses pineal GCTs. The treatment is GKS were recommended. And however, after GKS, then there's a acute obstructive hydrocephalus. So this boy has to do emergency VP shunt. So this is after VP shunt, and so then this boy was follow up for the lesions. This is post GKS 4 months, which review or progression was highly suspected. Then 2 months later, another MR scan was performed, and we see that the lesion was truly enlarged. So, summary of this case is the first diagnosis, and then primary treatments for GKS, then acute hydrocephalus have to do a VP shunt. And however, the FP beta stage was unknown, and imaging enlarged and clinical stable. So, follow up for 6 months, and the disease has a PD. It goes to our GCT MTT. So we perform a whole process solution for GCT kids, including the round and clinic and also the discussions. So this is the imagings after in our patient wards. So we see that the lesion enlarged quickly. So and then we also do the assessment, assess cytology, which was negative, and the whole spine was negative as well. So the pineal region, so pre-diagnosis pineal region anti-CCT secreting subtypes without disseminations, and tumor PD after GKS treatment, and the post-op VP shunt. So we perform a treatment plan, and step 1 is to by some steps. So step 1 is chemotherapy for 6 courses with close follow-up. We'll use the ACNS AB protocol with EIEC alternative. And step 2 is second look surgery, if necessary, then goes to radio. So after the first chemo, we can see that tumor biomarkers. The first chemo and the tumor biomarkers a little bit higher. Imaging was stable. This is the imaging. Then we go to the second course. Then the biomarkers down. However, the MR imaging still shows the lesion was enlarged. And as the disease progressed, then they have the severe midbrain compressions. So it has a PSH, prosegmental sympathetic hyperactivities. Tumor biomarkers decreased, but tumor size enlarged. So growing teratoma syndrome was highly suspected. So we have no choice but to operate. So we do the second look surgery. And so this is the our parts. So we after MDT treatments, so we have a chemo, but then GTS was coming, so we have to do the it has a PD. We have to do the operation. So this is the operation. So we use a lab open approach with the multiple pop entry projections, and we debug the lesions with the seizures and KUSA. It was extremely tenacious. Blood supply was mined, and the boundary was clear. So we debug and the lesions, and finally total activated resection. And the frozen pathology is the teratomas. So the intraoperative photos, and the vein of Galen was protected well, and the syringe brainstem and aqueducts. So the final pathology review 90% of the mature teratomas, and some also differentiated their tissues. So this is intraoperative neuromonitoring. And then after there's a management in our NICU, so we summarize the treatment as ABCDFG, so elevated the brainstem edemers, the breathing supports, circulation supports, DVT prevention, rehabilitation, feeding and guarding the woods, and healing the mentals. So in the day 2, then this boy awake, and then we saw the incubation at the day 3, and this post CT and MR scan, and the pre and post op. And after the operation, so we goes to another 4 courses of the chemotherapy, then finally goes to a CR for the biomarkers. So this is follow up and MR scan, and this is post of 6 months follow up, and so the boy complete with the chemo and the radio, and so for those NGCCD with the GTS, the primary treatments was very critical. So, and the treatment for IGCT requires MDT discussion and to make the plans. And growing teratoma syndrome should be paying attention during the NGCCT chemotherapies. It could be caused to emergency operations in this typical case. How to diagnose the GTS ahead of time still need more research. And the GTS, for those cases, after a successful operations, usually have a good outcome. This is the brief summary for my sharing. Is IGCT has a unique epidemiologies and classifications, and the diagnosis, assessment, treatments require MDT and more standard protocols. And NGCCD with chemotherapy, we have to pay attention to GTS. It requires more research. So finally, thanks to my teams and my colleague. So this is our pediatrics neurosurgery teams, and this is our department. And also, there's an old saying that you want to go fast, go alone. If you want to go far, go together. So, so welcome to Shanghai, and for the ACNS meetings, and let's come together and let's work together, and for the kids' brains we care. So thank you, and that's all my sharing.
Thank you, Dr. Wang. It was an extensive, comprehensive, and presented with clarity. I think I should congratulate you for having a very distinct protocol in your center itself. I don't see any questions at the Q&A. Maybe I can start off with a question. I think one important question which I thought, which is very basic, is why do you think the epidemiology is so distinct? The Asian population has not even. I mean, it's more of Far East. This disease does not happen in Indian subcontinent nor in the West. Did you find any explanation for this?
That's a very good question. Actually, I was also thinking
so actually,
a lot.
It should not be an Asian little boy. It should be a Far Eastern little boy. Yeah, truly. I mean, it doesn't happen in the Asian subcontinent too. I mean, in this Indian subcontinent, so a large population is still
really?
accepted. No, not much.
I learned a lot today for this. So I think there must be some, like a genetic backgrounds. I mean across the populations. So that's why I think for this kind of disease, we need to have a more cooperations across the Asia and also with the North America and Europe, because I see that there are some publications recently is for Korea, Japan, and so I think we need to have more international cooperation, like with NDS, different locations, and China to make this kind of disease to have to unveil the mystery. Yeah, I have no questions for this, but I think there must be some genetic backgrounds difference for this.
So I noticed in your protocol that suppose if you have an infant or somebody less than 3 years, in less than 3 years, we see immature teratomas and mature teratomas which occur congenitally. Now, if you look at as a pathology, they are a part of this whole spectrum, isn't it? So where does radiation come in that particular entity? Less than 3 years with immature teratoma.
Oh, you mean, sir, immature teratomas
In
for
less than 3 years, because radiation is a very important part of germ cell tumors, isn't it? So how do you how do you think you should handle it?
Yeah, so for kids that less than 3 years, then so we will use use chemo first, first chemo first, then to help those kids to when he grows then older than 3 years, then he can goes to the radio. But that's then 3 we don't radiate. So in that case, chemo will be done in the first, then goes to chemo when the kids grow up.
And then a spine as a location for teratoma, immature and mature, both. And germ cell tumors, primary location.
Yeah. You mean the location, right?
Yeah. Spine is a primary location. I mean, you agree that it can occur anywhere in midline, isn't it? So midline CNS is known. Midline spine, I have seen immature teratomas in midline spine. So again,
yeah, good questions. I don't for my experience, I don't see a lot of spine. I mean, don't see a lot of spine teratomas. So for our first speakers, I don't know, because he's a spine guy. So whether he has a lot of spine, but for in my case, I rarely see like a spine immature teratoma in our groups. Yeah.
Teratomas are very important congenital tumors. So, of course, they're a part of the spectrum, but they're, I think, a gently different entity by themselves. And then another thing which I thought I should point out, endocrine manifestation and psychiatric manifestation is very common in germ cell tumors. Psychiatric and endocrine. I mean, sometimes their first presentation is endocrine presentation. They come to the endocrinologist with diabetes insipidus, just enhancing infundibulum. I mean, this is a very important point in discussion. You have an enhancing infundibulum, and there you start the discussion of germ cell tumor and the differential diagnosis. Anyway, I think I should congratulate your protocol. It was a very distinct and very clear protocol. So congratulations for your protocol first. Raja and Bunseng, do you have more questions?
Yeah. I have a question for Dr. Barr. First of all, let me congratulate him and thank him for this wonderful session. I learned a lot from this lecture. Regarding the CSF examination, I would like to ask how much quantity of CSF do you send for examination for the beta HCG and all other markers? What is the quantity of CSF?
Thank you for the question. So for the quantity of the CSF for the tumor biomarkers, usually 3 ml is okay in our centers. So, but for the cell cytology, we need to have around like 5 to 10 ml. So in this case, we usually so if there's a germinomas with hydroceptors, we will do ETV. So before we do ETV, we have a punctures. So we will get the CSF before we put the ETV into the brain. So that's one case. The other case is if there's no hydroceptor for those germinoma cases, we'll do LP. So totally, we will get like around 10 ml from the patient. So 3 ml for the tumor biomarkers, and then the rest of the 5 to 7 ml for the cell cytologies.
Okay, thank you.
Yeah. I ask 2 questions, Professor. Thanks for a very extensive presentation. I have 2 basic questions. One is, regarding 5-year survival. Usually we give a 5-year survival for malignant lesion or condition which cannot be cured. And what do you think the long term, do we able to achieve cure, especially for mature teratoma cases? I hope to see, I mean, we don't talk about 5-year survival anymore in the future for mature teratoma. What's your opinion regarding this? My second question, Professor, you see, most patients, when they presented to us with germ cell tumor, they usually have some structural damage in the brain. What do you see in the future? Is there any possibility of any way of screening program? Although I know this is a very rare disease, but do you think foresee that we can do some screening program where we can identify those patients earlier? Thank you, Professor.
Thank you for the questions. So for the first question is that
on mature teratoma.
Okay, yeah. Yes, good question. That for the mature teratomas, we would consider that it can be cured up to the so because for the mature teratoma, like in our protocol, so we split into a separate types. So we were more regarded as their like benign tumors. So that's first one. The second one is for the germinoma, because right now the follow up we have more long term follow up. So right now we use 10 years survival rate instead of the 5 years, and the other one is to the recurrent rate for those kids. So we found some of the kids they are more than survival than more than 10 years. So it's a very good suggestion. I mean, for the later on, when we look into the germ cell tumors, we won't say 5 years survival rate. Will be 10 years, or we were talking about like a recurrent rate instead of survival rate. And but for NGCCT, maybe we will still have used the 5 years rate, because some of the cases they were recurrent and have the survival is still worse than germinomas. Yeah, and the second case is a good question as well, because right now we have some clinical trials, so we are trying to identify like germ cell tumors even from the eyes. I mean, we do some like eye testings to see whether there's connections between the eye and the pineals. It was interesting because, as we know, that the pineal actually called the third eye of our bodies, and it can affect the eye movements. So we'll check the vascular of the eyes and all the also some other like features of the eyes incorporated with our eye departments, trying to see whether there's some connections between there. And if there's a connections, then we can do some like screenings during the eye test. So yeah, so that will be a very interesting questions, and we are working on that.
Thank you, Professor Wang. Probably we can hear concluding remark from Professor Suhas. Professor.
Yeah, I think Dr. Wang, thank you very much. It was a very extensive, comprehensive, and as I started off with presented with clarity. Congratulations for your protocol. That's, I think, together, as you said, collaboration is important. You see lots of protocols, although the primary ethics and the tenets are same, but at the same time there are the values. Let's say alpha AFP values, HCG values, all are different in different trials. So that's, I think, a very curious question, which people who have numbers should collaborate to come up with one unified answer. Thank you very much, Dr. Wang, and thank you, ACNS, for this wonderful topic webinar.
Thank you.
Thank you,
Dr. Raja and Bhumia.
Wang. So we can conclude our second session today. On behalf of the Education Committee of the ACNS and the President, Professor Iqbato, I would like to thank both speakers of today, Professor Muhammad Abd-El-Barr and Professor Xiao Weng Wang, as well as our Chair, Professor Salman Sharif and Professor Suhas Udaya Kumaran, for the time and support for the ACNS webinar. A special thanks to Professor Zubin for broadcasting this webinar, and we have more than 360 audiences in all our 3 platforms. And also special thanks to our chief and host, Dr. Raja, for today arrangement. So till we meet again tomorrow, is bye-bye from us. Thank you, Professor. Bye-bye. Good night.